So this presentation is on our cardiac arrest tactic. We've talked about it for a little bit in EMS training. We've introduced it to somewhat in some EMT classes and done some testing. And so we're ready to roll this out now as a valid tactic for us to use and essentially an SOG in the way we do business on cardiac arrests. In the most recent 2010 guidelines that came out from American Heart, this concept of a pit crew for cardiac arrest, for resuscitation, where each person has a specific role and specific duties, has come up, and American Heart strongly supports it, and many services in various places have implemented it. And so this is not something that we dreamed up on our own, but we have modified what's out there. But this is definitely an AHA-supported concept. In addition to the Heart Association, there's a group called the Eagles of Major Metropolitan EMS Medical Directors from the most populous cities. Very interesting group, a bunch of strong thinkers who are moving and shaking things in EMS, and they have recently come out in strong support of this concept of choreographed resuscitation in terms of pre-assigned roles, and so that operations go much more smoothly. So in addition to the Heart Association, the Eagles are on board with this pit crew concept as well. Most notably, some very high-performing EMS services, Wake County, North Carolina, and the Austin, Travis County, Texas folks have put this into work, and they've produced quite a bit of documentation. You can Google for pit crew CPR, and you'll get several hits, and almost all of them will filter back to, in one way, shape, or form, Wake County and Austin, Travis County. And so, again, this is an adaptation of what they've come up with for what we believe will work for us, but they are strong supporters, and they have excellent results that have proven that this does make a difference in resuscitation outcomes. So what's this whole pit crew concept about? Well, again, it's assigned roles. It's knowing who's going to do what. Very similar to what we do with our fire tactics. We have a crew leader, we have hose, nozzle, we have tools. We know who's going to do what. And we know where people are going to be in our usual situations. It gives us a pattern to divide tasks, make sure that everything's covered and everybody knows what they're supposed to do, and still allow some flexibility. We should be able to integrate BLS and ALS, but the key thing is that those of us filling the BLS role, we own that CPR. That's our major responsibility. Let the ALS folks work with the advanced airways, medications, cardiac rhythms, and such. And there's quite a lot to do there. But the BLS folks should own that CPR, and the ALS team leaders should be confident that CPR is being handled by the BLS folks, which means us. Here's a schematic of the pit crew concept that's being used in other places. And again, we're going to modify this a little bit, but I wanted to give you an idea of what's out there in the literature on this. Basically, we're going to position people on either side of the chest, and they're going to alternate. And the two folks up at the head are going to take care of airway and ventilation. And then there's another person down toward the pelvis or toward the legs who's taking care of medications, cardiac monitor, and such. And then there's a resuscitation crew leader that's positioned typically at the feet is a good place for that. And so this, again, that's the crew leader of the resuscitation effort, not necessarily the incident commander in some of these models. We felt like we ought to modify this a bit, but I wanted to show you what was out there from Wake County and Austin and places that are doing this. So here's what we're suggesting will work best for us. We've got color-coded for the blue, will be the BLS folks, and then the gold or orange color are the ALS people. And we realize that the ALS crews are not coming with 2 paramedics every single time, but we expect that they're going to position their people in pretty much this way. So our first 2 folks in the door will be lined up and taking care of position number 1 and position number 2. One will be at the chest, one will be at the head. We'll describe these roles here in a little bit more. Then the next person in the door is going to alternate at the chest so that we have the ability to switch off on that CPR. And then as we bring additional people in, will fill the IC spot. Obviously, initially, one of those first two folks will be doing it, and then we'll just alternate in the 2 and the 3 spot. And then when the medics arrive, when the ALS crew arrives, then we have a place for them to be. So this is kind of a standard way that we'd like to do stuff. Obviously, there'll have to be some modifications from time to time based on individual situations. But in general, this is kind of the SOG on who's going to go where and what they're going to be expected to do. As I mentioned, we've got 2 assigned roles. There's head and there's chest. We may put more than one person at the chest. We may decide that a second person up toward the head, particularly when we start messing around with Combitubes and such like that, maybe that would make some sense. But we're going to fill the head and the chest role first, and then the next person through the door is going to take care of the chest. These are choreographed actions. We know who's going to be where. It's very similar to how we do business on the fire ground, and we know it will work. Plus, we've left space for the ALS crews so that they can put people where they want to be and where they need to be to do their things, while we can continue to do what we're responsible for. We need to own the CPR, own the airway and breathing and the chest compressions, and so we're going to put our folks in these positions in order to make that happen. So kind of summarizing those last couple of slides, again, the head person's going to go up there first. You don't have to, it doesn't matter which side you're on, but you're going to be at the head. Job will be to manage the airway and hold a mask seal, and then the next person to the chest and take care of chest compressions, AED, and the squeezing of the bag valve mask. Then we'll put a third person in there to alternate with CPR, leave room for the medics to get in where they need to be, and we eventually need to have somebody who's overseeing the whole process standing somewhere out of the way, which is typically at the feet or in that general area. Person at the head's job is to maintain the airway using a head and neck positioning, orals and nasal airways, and maintain that mask seal during bag mask ventilation. That is a 2-person task to use that bag valve mask. One of the people is going to be consumed with holding the airway and getting that mask seal. Suctioning would be handled in there as needed, but this is the key thing on here. The person at the head does not do the ventilation. They hold the mask seal, hold the airway in place. The chest person will take care of squeezing the bag. Person at the head's in charge of airway and breathing. Person at the chest is in charge of circulation, compressions, AED, defibrillation, all those sorts of things. The person at the head owns the airway and the breathing part of this, but simply is not going to do the actual ventilation. We're going to have the chest person reach over and squeeze that bag. But the head person will then also become the assistant to the ALS crew. And we've done some training on this in recent months in EMS training. We'll do more. And so that person's job is not over when the medics come in. That person becomes the assistant to the ALS crew. And then if that ALS crew is delayed or gastric distention has become a problem, it's the head person's job to determine that it's time to use that Combitube. Remember, we're not using Combitubes right off the bat. There isn't a need for us to jump right to that. It pretty well locks the medics out of getting the tracheal intubation, which is the better airway. So it's that head person's job to be making that judgment call. Can we wait a little bit for the medics to get here and get an intubation, or are we going to have to go ahead and use that Combitube? And that's up to the head person. The IC is not going to make all those decisions. The head person is responsible for taking care of the airway. Again, back to the overall diagram of where we're going to try to go and what we're going to try to do. And we pretty well talked about what this number 1 position is going to be, and they'll be the assistant for the ALS person assigned to the head when they get in there. Obviously, if we just have 1 or 2 folks in the door to start with, one of them is going to be functioning as the IC, but once we have that 4th person on the scene, then we ought to pass that IC task out so that someone can adequately cover all the bases there. Okay, so we've talked about the head position. Now let's talk about the chest person. This is the person that does the squeezing. This person's going to squeeze the bag valve mask. They're going to take care of chest compressions. They're going to deal with the AED because they're either doing AED things or chest compression things. But again, They're the ones squeezing the bag. We've practiced this and tested this with a lot of training setups. We're confident this is the best way to go for those cases where we've just got a couple of folks available. And once the medics get involved, there's also just not enough room for us to have 4 or 5 or 6 of our folks crowded around the patient. So we want to stick with this throughout. The chest person takes care of squeezing chest or squeezing bag valve mask. Now in those cases where there's a mechanical CPR device, the auto pulse that Boone's using, in that case the chest person is still responsible for bag mask ventilation and remain in position to take over chest compressions as needed. So once the auto pulse is there, it does not relieve the chest person of all their duties. The chest person needs to stay in place, monitor that device, and be ready to take over should need be. So our first 2 folks through the door, one's going to go up to the toward the head and be the airway person. Probably a good place for the red bag would be right about there. Second person's going to go to the chest, doesn't matter which side. Probably want to place the AED down in that range. You don't want to get it up in the up in this area here. Remember, that's where your ALS folks are going to go. Third guy through the door, going to take over chest compressions on the opposite side, from whichever side it was, opposite side from where the second person is. And this gives our ALS people room for their monitor, their med bag and such, as well as their airway stuff. And this will just make things much smoother. So we've talked about first person through the door is going to go to the head with the red bag. Second person's going to go to the chest on one side or the other with the AED. Third person in the door then would go to the opposite side on the chest. Fourth person through the door can probably assist at the head and might be in a good position to take over some of the IC duties, as well as just look for scene safety and perform that cover role as best as possible. But that person may well go to the head, particularly if we're going to do Combitube, to have a person who can just concentrate on prepping that device, ruling out all the contraindications and such. That's probably the best place for that fourth person to go. Then as we have additional people arrive, it is helpful to the whole process if we can gather accurate demographics and correctly spelled, legibly documented patient name, date of birth. Any history, any medications can be gathered. We can do some family assist. We can narrate for the family, describe what's going on, and then there's all the things to prepare for transport. And remember that in most of our medical arrests, there's not a reason to transport rapidly, so probably the history gathering and the family assist will take precedence over backing the truck around, getting the cart, and those sorts of things. On a traumatic cardiac arrest, it's all about hurry up and go, but on medical cardiac arrests, it's about doing the best we can in those vital first few minutes, and we just can't do as good a job if we're trying to transport as well as resuscitate. So just remember, third person's going to the chest, fourth person can assist at the head, take over some of the IC roles, maybe deal with that Combitube if the medics are going to be delayed. And then as we gather 5 and additional people on the scene, then we can start filling out some of the logistics roles, as well as that critical role of assistant family. So we've described an SOG, and an SOG is just the usual way that we expect things to go, but the incident commander certainly retains the responsibility and the authority to make adjustments and assignments as necessary. The incident commander is responsible for the event as a whole, for the incident as a whole, not necessarily the individual medical decisions that are made. The ALS crew, we expect, will assume care for the patient and make patient care decisions, but we don't ask them to be involved in complex patient care, particularly those patients that are resuscitated that become very complex and dynamic. We should be able to manage scene logistics in coordination with them and communication with them, but they're not supposed to have to manage the entire incident. That's our job with Incident Command and our role to do. So just wanted to clarify that this is the usual way we're going to do stuff. The Incident Commander certainly has the authority and the leeway to do what makes the most sense. And let's try to let those medics focus on doing medic things, and we can take care of a number of support roles, and they can count on us to own that CPR, for us to do outstanding BLS care. That's what's going to end up being the best overall for our patient. So that's how we're going to go forward. That's our SOG for where we're going to go and what we're going to do, based on some stuff that's worked on a national basis with various places, but we've modified it some for our deployment patterns, our staffing, our situations. And we want to make sure that we leave good spots for the ALS folks to get in, but that we own that CPR, and that we know where we're going to go and what we're going to do. So as we work through this, if you have questions, you have comments, as incidents occur, please pass that forward through the operations side. Contact us directly in the training bureau if we can help. And we look forward to seeing even better outcomes from our cardiac arrest situations in the future.